to today's webinar, Navigating Precision Health with Population Genomics. On behalf of Becker's Healthcare, thank you for joining us today. Before we begin, I'm going to walk through a few quick housekeeping instructions. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We're here to help. With that, I am pleased to welcome today's speakers. James Liu co-founded Helix in 2015 and now serves as CEO. He previously served as president and chief scientific officer and led the development of Helix's Exome Plus assay and pipeline and established the company's CLIA/CAP lab. James holds an MD and a PhD from Baylor College of Medicine and received a BS and MS in chemical engineering from Stanford University. Leslie Dawkins is the vice president of primary care and operations at Health Partners, joining in 2016. She is a registered nurse with over 20 years of healthcare experience, committed to safe, efficient, high-quality care delivery, and has extensive executive experience working in both the for-profit and not-for-profit healthcare sectors. Leslie holds a master's in healthcare administration from the University of Minnesota. James and Leslie, thank you for being here today. James, I'll now turn the floor over to you.
First off, thank you everyone for attending, and thank you, Beckers, for having us. Leslie, obviously, thank you for doing the webinar with us today. Maybe as we get started here, just a bit of background about Helix. Helix is the leading population genomics and viral surveillance company, and our main focus is on working with major IDNs, integrated delivery networks, on population genomics programs, where us and the leading health systems really share a belief that genomics is going to become standard of care. So we'll spend a lot of time talking about that today, but just for background as well, Helix also operates a viral surveillance network focused on a public-private partnership with CDC for viral early warning, which has obviously been a big part of the pandemic here. And then we also have a fairly large COVID operation, which we'll spend hopefully no more time on, and we'll be able to eventually wind down over time. As an organization, incredibly excited to talk about what we're doing in population genomics and our partnership here with Health Partners. So I'll turn it over to Leslie to talk a little bit about their organization, and then we'll go from there.
So hi, everyone. I'm Leslie Dawkins. And again, thrilled to be here to share the great work that we're doing along with Helix in this space. So Health Partners is both a care delivery system and a care financing organization. So we have a health plan across 5 states with 1.8 million members. And then in our care delivery system, we are in Minnesota and Wisconsin. And we have 1.2 million patients. We have 2,700 clinicians. We have over 55 clinics. We have dental group. We have 8 hospitals. And, we're best known, I think, for our quality work and our work in total cost of care, and really strive to always really support our patients in health and well-being and in partnership. I love our vision, which is not on this slide, but I just feel like I have to say that. But health as it could be, affordability as it must be, through relationships built on trust. And we feel this program is right in this wheelhouse.
Just a bit of framing as we think about population genomics and the use of genomics in the care system. We often think about its service in achieving the quadruple aim. And much of our work, which we'll discuss today, is around how do we use genomics as part of standard of care to achieve both population health, but individual health as well, but also the use of the genomic data as a mechanism to drive total cost of care savings over time, as well as enhance patient engagement and experience with the healthcare systems. Lastly, a lot of our work around genomics is making sure that it can be adopted at scale and make it easy to do. And so much of that is focused on how do we drive speed to answer, as well as better experiences providers as they adopt new technologies that we think will become a common part of medical practice in the future. A big part of our belief is driven by how we think about health determinants broadly for care groups and provider systems are thinking about what different ways we manage risk across a population. And so often when we talk about health determinants, there's a big portion of it focused on behavioral risk, which are decisions we make around diet and exercise, smoking behaviors, et cetera. There's obviously a big component focused on environmental impact as well as social determinants and how that impacts disease outcomes as well as health equity. But a big portion of it, probably about a third of the overall risk, is also related to biological data. And historically, biological or genetic information has been hard to access for systems at large. Historically, it's been fairly focused on narrower populations. And so when we really think about enabling systems to really manage populations over time, we think about how do you uncover this information, allow it to detect patients earlier in the journey in order to prevent disease when it can be impacted, and how do we kind of make that data available and liquid throughout the care system. And so much of our focus is on how do you make that seamless and digital, and how do we drive changes in care. An example of how some of this care gets delivered is in some of our early work on use of genomics as a screening mechanism for disease. And this was done in this study was done and published in Nature Medicine in 2020, focused on the first 30,000 individuals who did a system in Northern Nevada, a partner called Renown Health. And we focused there just on the use of genomics as a mechanism to discover undetected disease. And we focused on three main conditions there, which are often grouped together as the CDC Tier 1 or the Tier 1 actionable genetic conditions. That includes things like familial hypercholesterolemia or inherited high cholesterol, resulting in cardiac events or strokes, Lynch syndrome, as well as hereditary breast and ovarian cancer related to BRCA1, BRCA2. And we asked kind of three main questions around that. The first one is, how often do we find carriers in the population in an unbiased collection of individuals? So these were individuals who were elected to be part of a translational research study, who were collected from the communities, where the only inclusion criteria was that they were over the age of 18. The second question we really asked is, in the context of typical standard of care, how many patients would have been detected or undetected in the typical clinical practice? And the third was, what is the disease prevalence and morbidity of this patient population? And we were very, very surprised if you use genetics as a broad screening mechanism in this particular study in what we found. And I think one was we found about 1 in 75 or 1.3% of individuals were carriers of a pathogenic finding in one of the 9 genes we looked at here for these 3 conditions. But more interestingly, we found that over 90% of individuals would not have been detected or were not detected in typical medical practice. And I think of particular note, when we went back and ascertained family history for all participants in the study who were carriers of BRCA mutations and Lynch mutations, we found that over 80% of them actually had no documented or no ability to recall family history that would have qualified them for testing. And so when we looked at the disease impact on these patients, it was very clear that genetic screening or use of genetics as a kind of standard of care tool would have been one of the only mechanisms for detecting disease early or disease risk early and for driving important interventions. And so as we think about the use of genomics from a historical basis to where we would like it to be over time, many of our uses of genomics have been very much treated as point solutions. How do we identify a cause of a disease in a particular patient today? And I think that really misses the vast majority of patients who would benefit from a population level approach to use of genetics over time. The second one is genetics has often been treated as a one-off test used in a particular point for decision making. But as we think about the use of genomics as part of a care system over time, I think we very much think that genomic data, probably completely unique in the ecosystem of healthcare data, is the one data set in healthcare that does not change with time. And so it lends itself to a model where you can digitize it. If you store it and generate a high enough quality of it, you should be able to come back to it again and again throughout the care of that patient. And that digitalization of the data drives both speed to answer, so almost a point of care type experience with genetic data over time, but also the ability to leverage it over and over again for much better speed to answer and much better cost structures. The third piece of it is that obviously genomics has been used in a very focused fashion from a diagnostic perspective, and also has been explored in a research perspective, but they have not been combined in a way that allows us to continue to build upon learning health systems and build that kind of research backbone to drive future applications that really change the way we care for populations over time. And so we've been thinking about these three main characteristics as a way to really drive a transformation in how we pull forward kind of genetic strategies across healthcare systems, and how do we generate the right kind of outcomes that would make healthcare systems think about use of genomics in a broader fashion. And we often find that within our partner systems that they bucket the use of genomics into three main categories. The first one is obviously clinical impact, which we discussed a little bit about today, and the use of identifying patients earlier in the care journey when we can really impact diseases before they occur. The second one is obviously thinking about how we can work and engage our patients and our providers. And the third is how do we drive continued innovation in our healthcare systems, both from a research and health systems integration perspective, but also from how do we partner with other industry players and other third parties around opportunities like clinical trials and driving some of these new therapeutic and diagnostics in a novel way. And so we've been building population genomics solutions that enable our health systems to adopt this at scale. And we really believe that an integrated approach is going to be really important for this to be successful. And having worked with a variety of organizations like Renown Health, Mayo Clinic, Medical University of South Carolina, and now with Health Partners, really start to refine many of the toolboxes that will be required for these programs to not only scale within the context of care systems, but also ensure that they can be successful and have a minimal impact on the staff as we kind of bring them out and make this data available broadly. And so we engage in all parts of the operation, from recruitment and engagement, obviously through data generation, but also the access and use of these data from a clinical perspective, what we call kind of digital testing or reuse throughout a care system. So I'm going to turn it back over to Leslie to talk a little bit about the program, and we'll go from there.
So yes, we're super excited to launch our program named Mygenetics. Our goal partnering with Helix is to recruit over 100,000 participants in the next 4 years. The exciting thing about this program is it's voluntary, but the cost is free to our patients. And we want to be able to bring this information to individuals as a preventative screening. You know, our ultimate goal, start with the end in mind, is that we really would love for this to become a part of normal primary care practice, to be able to impact someone's health, intervene early, change their trajectory. And so we know that by participating in this program with Helix, we're enabling the research that hopefully is going to drive change in policy, drive clinical utility, and prove how this population screening can be effective. And we want to be on the forefront. We know this is the future of healthcare. We know this is something that more and more people are interested in, and we want to be able to provide both our patients and our clinicians with this information and do it in a way that makes sense, that is clear, and doesn't leave lots of questions in individuals' mind. So we're really excited, and we're right in the beginnings of putting everything together. Our goal is to launch this at the beginning of May. So several years ago, our health system kind of stepped back and said, who do we want to be in this genomic space? And, you know, I, along with some others, was tasked with trying to understand where should we focus, what makes sense for us as both a payer and a care delivery system. The world of genetics can be a little daunting, and there's so much information out there. So as we started looking across the country, just a few years ago, there was only a few systems, and there was some niche programs that were out there, and we weren't seeing a lot of individuals really look at population health screening. So we started to explore what our options might be. And I had the pleasure of meeting James at a conference a couple of years ago, and so we started this dialogue. But you can see, just even in the last few years, these programs are exploding. Individuals different systems are looking for partners in this space, and everyone may have a little bit of a different focus, but it's clear that the future of medicine and care there's a place here for genetics. And so we wanted to make sure we were a part of that and with a partner that we felt confident in that was going to bring us good information. So our team really, when we step back to define our strategy, our clinicians, our health plan, because again, we're a payer and we want evidence-based policies to determine where we spend money, where there's clinical utility. We said we want to do this work, but we want to do it responsibly. We want to make sure that we are bringing this new data and information into clinical practice, but we don't want to play in the game of unknown variants and those types of things. So we wanted to take information that was proven, that was shown to have benefit to patients. So we decided we were going to start with those tier 1 diseases and make sure that we could focus in a place where we knew we could be actionable and where we knew that we had clinically proven care pathways that our clinicians would feel comfortable about. And we knew that this could actually benefit patients. So as we move into this program, our mantra with both our clinicians, our staff, and our patients around this is not only are we going to be able to impact an individual's health, but we're going to be able to impact the health of their family. And then we're also going to be able to impact the health of our communities and the world that we live in. So appealing to those individuals who want to learn for themselves how to better know their risk and mitigate those risks and then be able to support their family and the community. It's exciting that we could be a part of the research to bring this into normal clinical practice. And then honestly, we also want to be a part of in a partnership that we can bring new information as it comes and integrate it into our records. We are excited about potentially moving into pharmacogenomics. So again, as more and more information is proven and there's not controversy around the clinical utility of that information, we want to get that into our care system as soon as we can. And of course, we have a broad patient base, and we also look at this as an equity opportunity. Before, the cost of genetics and the ability to be screened has been so far out of reach for so many individuals because of just not having exposure, and then of course insurance not covering a lot of testing unless there is a need. And so this is an opportunity for us to engage across multiple populations, have it free to anyone who's interested, and we're excited about bringing that to our community as well. And we've done a lot of work with our clinicians and our care teams to really socialize this and make sure that people felt good about the work that we were doing. I think the fact that we approached this only focused on the tier 1 diseases first. In our program, we are not returning any information back to the clinical record other than those tier 1 results. And we are creating workflows, which we may get into a little later, where we are really trying to make sure that the clinicians are not in a position to have to recruit individuals for this work, and that we are surrounding them with the construct and support they need, so that as we move through this process, patients are given information by genetic counselors, someone else is calling them with the results, and guiding that initial part of the care so that the physician then is engaged only when they are needed and where they are needed. And our teams are very excited about this. All of our leadership has been involved in these discussions. We started with physician champion groups with each of the key specialties, and really built a lot of energy and excitement around this. And then we made sure we pulled in our ethics team, and of course our senior leadership team, very engaged. And this has been, like I said, a 2-year process that we've been building the momentum around this before we got to the point of launch. And we really believe, number one, this is going to define us in this space. we want to be on that map of systems who are learning how to use genetics in care delivery and incorporating that into our care pathways. This is absolutely part of our mission to improve health and lower the total cost of care. When we look at the fact that we can digitize this information and it can follow a patient, no longer do we have to have multiple tests every time there's a clinical need. The cost to just recreate this data is much lower. And then, of course, if we can change someone's care trajectory and avoid the acute, high-cost, advanced diseases that occur, acute episodes and high-cost diseases that occur in the future, then we're doing the right thing by our patients as well. And then we think this will attract both new patients to us, but also new clinicians and those who are excited about this work and want to be a part of the research. And then knowing that we can be, again, some small part of advancing this for the community at large, that's exciting for us as well. So this may be the opportunity that we need to turn it back over for the rest of the group.
Thank you, James and Leslie, for a great presentation. We can now begin today's question and answer session. You can submit any questions you have by typing them into the Q&A chat box on your webinar console. Let's get started with the first question. This one's for James. This program sounds really exciting. Do you have any other programs with other health systems underway, and how are they going to go if you do?
Yeah, it's a great question about, maybe I can also take it at a kind of a more of a market level of kind of what we're observing across the country as well. So we've been engaged in population genomics for the last couple of years. We have a couple of different partner systems that have been in different stages. As I mentioned earlier, our first and kind of farthest along project is a program with Renown Health that we started in late 2018 at this point. We saw Mayo Clinic go live in 2020, Advent Health in 2019, MUSC in 2021, and Health Partners here in the next couple of weeks to months. All of them have kind of engaged in a very similar approach, which is there's sufficient clinical evidence to suggest that genetic screening is going to be helpful and useful from a clinical outcomes perspective. So that's being deployed very broadly. And then the use of these data, genetics data, to be used as a digital resource kind of throughout the care system is one of the key goals of all these programs. We do operate these with, as we were mentioning, as a research backbone. And part of that is also that we're generating translational evidence, not only for broader use of screening techniques, but also for other applications in the future that we think will impact different populations of patients. So we're really excited about these programs. They're really kind of growing at this point. And I do think in the next couple of months to years, we're going to see much more widespread adoption, particularly as more and more organizations decide that genomics is going to be part of their standard of care over time and part of their part of the future of medicine.
Thank you. This next question is for Leslie. It says, I'm assuming getting this program up and running required buy-in across the leadership group. How'd you go about that? Were there any issues?
So again, I think this was something that we spent a lot of time socializing before we actually moved forward with the program. So I think we started with the leadership team, our senior leadership team, and got some of the common questions that everyone asked out. And then we took that to our ethics committee, making sure privacy information, how are we going to protect individuals? How do we make sure, we don't have disparities and as we recruit patients. So all of those questions we brought through to teams. We, like I said, talked with our ethics committee. We got answers that we felt comfortable with from Helix through the due diligence process. And then as we took this to our individual clinicians, we started with a clinician champion group. So again, pulling the clinician leaders from each of the key specialties that would be impacted and ask what their questions were, what information would they like us to bring back to them. As I'm kind of reviewing some of the questions, I think some of the biggest questions that always come up is, is this going to have to happen in the exam room? We don't have time as we're, moving through our normal patient flow to recruit, to educate. So we had to create those support structures and create those assurances that we were not going to ask individuals to do that. And so just a lot of individual sessions, bringing to primary care leadership team, bringing to our laboratory teams, and gathering everyone's questions, going back, getting those answers, and bringing it back to the point where people got comfortable and started to get excited. And I think as you start this journey, what you will notice is there's always a lot of concern and trepidation in the beginning. And then as you socialize more and bring more information forward, people's comfort level starts to expand and the concerns start to come down. And just having consistent messaging and continually updating information, addressing the questions before they get asked in your presentations, and once you have information, I think was key for us.
Excellent, thank you. This next one is for James. It says, how do you see a program like this working at a health system that already has sequencing capabilities?
Yeah, it's a great question. And we often have this discussion with local pathology or local labs that have some sequencing capability. And I think the real question is the system ready for population genomics, and does the institution have the capability to deliver that? And often what we find in institutions that have sequencing capability is that capability is particularly reserved for situations like oncological testing or for other things that have a real need for very fast turnaround time for surgical decision making, let's say, and that most of them aren't running kind of factory-like operations for population level sequencing. And so those are just different types of investments, and they check different strategies and needs for the health system. So I almost always find that it's easier for parties to work with Helix if they already even if they already have sequencing capability, because we do a different thing for them than their local sequencing capability.
Thank you. This one's for Leslie. It says, what made you start thinking about doing population genomics at Health Partners?
Again, being both a payer and a provider, I think we struggled with the fact that there were so many opportunities in the genomics space. Our clinicians were seeking guidance of what's the right test, what's the right use case. So our lab team worked very closely with our health plan to really create evidence-based policies to support genetic testing. And as, again, we continued to evolve that work group, who was very engaged and supportive and trying to find key partners from a cost perspective, number one, to make sure our testing was appropriate and not, we know the range of genetic testing and that cost. We started to really struggle with where do we want to be in this space, and how do we want to make sure that we are driving evidence-based practice on both the health plan side and the care delivery side. And so that's what got us interested as we started to see all the different uses of genetic data and what we were being given by different labs, what were being requested by our clinicians. We thought we want to kind of lead and help guide our clinicians with decision support versus letting individuals or different companies press upon us their choices. And so we wanted to just take a little more control in that delivery.
Thanks, Leslie. Our next question from the audience says, how will this be at no cost to the patient? Will the payer provide reimbursement, or cost of sequencing will be paid by Helix or another partner?
So and James, you can help me with this too, in this partnership, and as we move into this as a research study, this is part of the arrangement that we came into to be able to have this low-cost testing, to be able to understand from a research perspective the population uses with the genetic testing and bringing that information forward. That's how we're introducing this. As we move forward, I saw another question in the chat. If there is a clinical finding associated with one of these tier 1 diseases, any subsequent follow-up outside of the genetic counseling visit, the genetic counseling visit will be free with the service of the testing, but those other tests and follow-up will be billed as normal as a part of medical care. But because we are in this research study, that's how we'll be able to offer that for our patients free.
My only comment is, as we build these programs, they are investments on both sides. And I think the biggest thing that we've been excited about in our partnership with health partners is that it is incredibly strategic, and institutionally, we find the commitment to really transform care in a way that's going to make genomics a part of everyday practice. And I think that institutional commitment is incredibly important for these programs to be successful.
Thank you. This next one says, how has this process affected extra staffing and extra resources at your medical enterprise?
So as we start into this program, I think people are very concerned about that. So, we do have the benefit of having a research team, and that's a part of our organization. So I think, and maybe I'll just high level describe the workflow so you can get a sense of this. So we use our marketing team to help recruit patients. Our Epic team is involved in, obviously integrating care pathways into our system. But the normal marketing, we set aside some money to be able to help market and push out information to patients to engage them in this process. We already have genetic counselors in our system that support oncology, cardiology, MFM. So we are taking those existing resources to be able to respond to any positives. I think when you look at James' data and the history that we've seen before, we're assuming we may have one positive a day. So as you start to look at this across scale, the volume doesn't seem that large to be able to handle. We have built into our program the addition of genetic counselors if we need that for the future. So there is an investment there. We have identified a single nurse who is going to know this information well, be able to call positives to patients. And I think as we see this progress, we'll understand what additional resources we need. But our lab teams, our primary care teams are super excited and engaged. And most of the work is happening electronically outside of the exam room. So again, the recruitment, someone being able to go sign the consent, all of that happens electronically. People will show up to the lab for a lab visit. Because our COVID volumes are significantly decreasing, we think that will help fill some of the gap where we were already staffed to accommodate those needs. And then the return of results will go through our MyChart and our normal pathway there. And then the genetic counselor will follow up with that patient. So I would say the biggest resource need is that genetic counselor if you don't have that within your system. And then we'll build care pathways into our EMR and our normal health maintenance, which will just become a part of normal clinical flow for screening if someone is positive for follow-up. So I hope that helps maybe define that, and we'll learn as we go where we have additional needs.
I would say, just a comment from in our implementation cycle, there's obviously a process where we implement a lot of the digital workflows that does require engagement of the teams in a pretty focused manner. But for example, we've gotten programs up and running from get-go kind of in three months, so about a quarter from end to end. And so while there is some very focused effort, our goal is on an ongoing basis, how do we make it as labor-free as possible? How do we make sure it fits within the current health maintenance or care coordination teams for the follow-up, and making sure that care loop does get delivered and gets closed for all the patients who have positive findings. And then as Leslie was saying, what we find on the genetic counselor side is that at scale, typically is about one patient per day. And so with a positive, say, BRCA finding or a familial hypercholesterolemia finding. And so In those cases, I think that typically gets accommodated within the current staffing. If not, that's something that Helix can help with.
Thanks, James and Leslie. This next question looks to the future a bit. It says, do you have plans to address additional genetic anomalies or diseases? What's next?
I can give my comment, and maybe Leslie can give her view on it as well. So we think the opportunity set for additional return and additional value is very large. But one of the key things in the way we think about phasing of these programs is to ensure that the care system is ready to receive them and that patients get the best care. And the nice part of having it be a digital asset over time is that you can decide to make those decisions later. So for example, starting with the CDC Tier 1, and you want to expand to, say, the ACMG, which is the American College of Medical Genetics, 59 or 73, et cetera, those now become digital queries, which means you can make them both prospectively and retrospectively on patients previously analyzed. So that just creates a lot of flexibility. And so we often like to operate at the pace at which the health system is able to operate to ensure that we can achieve high quality care. And we're less focused on just increasing the number of diseases off the get-go.
And I would say from our perspective, again, going back to the course we've chosen to take is we want to innovate and integrate responsibly. So for our clinician base, these are going to need to be well proven, clearly understood, accepted across the medical community before we would involve those in our record or take that information and put it into our record. So I think starting with CDC Tier 1 gives us a really nice base to learn from, to see the impact to our care teams, to see impacts to patients, to see the response that we get from the community, and then allow us to expand based on our clinician interest and, again, what has been clinically proven to move forward.
Thank you. This next one's about data security. It says, this is a lot of data. What are the measures in place for data security?
It's a great question. So let me take this one first. So it is a lot. It's a lot of data, and we obviously are aware that genomic data is some of the most precious to individuals, and so our philosophy on data first. Besides, I'll talk about security, but just generally our philosophy on data is that it's owned by the patient. And so part of Helix's role as kind of a steward there is to enable patients to take that data where they want to take it, so they can transport and make it portable with them as they travel throughout the healthcare system over time, but also that they understand what things they are consenting for and what uses of that data are available. So that's all kind of through a Helix account that they can access as a patient portal. From a security perspective, security is existential to the company. So obviously Helix is HIPAA certified, SOC 2, et cetera. But we take very, very seriously the right type of encryption, both in transit and at rest, all the different pieces of making sure that the data are protected and ensuring that we have all kind of the right security controls. So it's something that we take very seriously in all parts of our organization and how we think about working with healthcare systems. And it's a continuous process for us. And so we continue to improve over time and continue to make that data more secure, more private for our patients.
And James is definitely the data expert, and I can't speak to all the nomenclature there, but we, again, with our research team, we are one of the participants in the All of Us study. And so it was very good for us to know that the data construct and the securities were in the same format for both that study as they were for this work with Helix. And so it was quite reassuring to our team.
Thank you both. This next one is for James. It says, where do you see Helix in 5 years? Is it aimed to have more of these types of partnerships and expand the capabilities you can provide?
Absolutely. So I will try my crystal ball, but my last 5-year plan was slightly interrupted by a pandemic that we did not plan for. But our general view is that population genomics is going to be a foundational tool in medicine. And so our focus very much is enabling care systems to continue to use that data, expanding the use of those data within the context of care, and driving improvements in outcomes. And so from a very simplistic basis, we're very focused on how do we improve care outcomes, how do we lower total cost of care, how do we think about our health systems when they take risk, and we think about the shift to value-based care over time, and how do we continue to drive all that forward with genomics. And so what that means over time will be, certainly will be an expanded set of applications, a broader use of digital testing or digital use of data over time, as well as simplifying workflows and making it easier and easier for different parts of the care system to leverage.
Thank you. This next one says, how does this fit in with Health Partners' historical total cost of care focus? Leslie, I think this one's for you.
Yeah, I think this, again, is exciting for us in terms of truly impacting cost of care and acknowledging the affordability that must be there. So number one, on the care delivery side, once an individual is sequenced, then any future use of that data can just be requeried. So that is a significantly lower cost than if we had to retest them, having a different, genetic test going through different lab. So that is critically important to us. As a health plan, we have members who stay with us for an extended amount of time over their lifetime. And so being able, again, to identify disease early and intervene is more cost effective than finding someone with advanced disease in the future that will have all the healthcare costs associated with that. So we feel like this is absolutely the right thing to do in terms of not only impacting health, but impacting the cost of healthcare. And again, that's why we're excited to engage in this, to really prove out these ROIs, because we know that that's always a struggle for individuals who are wanting to use genetics in this way.
Thank you, Leslie. Our next question says, how can other healthcare systems get started in offering Helix clinical genomic testing for their patients?
Well, I think the probably easiest way is to call us. We're happy to work with a wide variety of health system partners. We're very easy to find on helix.com, but if anyone wants to send me a personal note, I'm happy to talk after this. It's james@helix.com. But we're very focused on how do we enable these transformations at scale and working with care systems that really do believe that this is going to become standard of care. So we're really looking for like-minded partners who are excited about walking that journey together.
Thank you. We have another audience question that says, which patients will be offered the clinical genomic testing? If it's open to everyone, is it first come, first serve? Do you do any outreach to historically underrepresented groups or to certain demographic groups that may be missed by the first come, first serve approach?
So criteria is anyone over the age of 18. I did say there was a question out there about pediatrics. I think there's just a lot of controversy in that space, and it's not a place that we wanted to start. So anyone over the age of 18, completely voluntary. We have done a lot of work through our COVID vaccine work, reaching out to our communities of color and other populations to really try to make sure we're equitably moving care forward. And so we're going to take some of those same learnings in our partnerships within the community and influencers to be able to help people understand what this is and why it could be important to themselves and to their families. We want to make sure people understand there is a research component to this, so information will be used for research, and just really do everything we can to educate, but make sure we have focused efforts in our underserved populations so that they're clear and understand what the opportunity is and what it could mean for them. I think, you want to be very careful that we don't want this to be seen that we're trying to to move this forward against someone's will. So again, being very, very thoughtful, making sure we're very clear on how the program works and the voluntary nature of that.
Thank you, Leslie. That is all the time we have for today. I want to thank James and Leslie for an excellent presentation and Helix OpCo for sponsoring today's webinar. To learn more about the content presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. Thank you for joining us, and we hope you have a wonderful afternoon.